Welcome, viewers and listeners, to The Tooth and Matter with your host, Dr. Chris Hughes, who I am giving this presentation. Okay, so we've talked about some different things so far. We've talked about dental implants, and we've talked about sedation in dentistry. Today's topic is going to be very interesting, I think, for most people. It is about regenerative dentistry. I would imagine probably no one has heard about regenerative dentistry. So that's what we're going to be talking about. Certainly people have probably heard about regenerative medicine, where, basically tissues are being recreated now. There's also transplants and things like that. But what basically the idea is to help the body regenerate and repair tissues that have been lost. Okay, so that's what we're going to be talking about, and probably people are wondering, well, why? How can you do that in dentistry? So we're going to jump right into it. So first of all, to understand regeneration and how it works and how it applies in dentistry, we have to kind of take a step back and think about, well, why do we need to have that in the first place? So, regenerative procedures come into use usually if we lose a tooth. So, in the past, people, if they lose a tooth, they just lose the tooth. And I've had a lot of people come to me and say, well, I had a tooth pulled. And I'll say, okay, right, that's okay, I understand that. Has there been any discussion about what comes after that? Because removing the tooth should never be the end all of a discussion when it comes to having to remove a tooth, unless it is a wisdom tooth, in which case usually those have to be removed and we don't need to worry about doing anything regenerative. But wisdom tooth removal is probably in the far minority of teeth that have to be removed. Most teeth have to be removed because they've broken down and there's been a lot of decay around them or gum disease, and they become painful and they have to be removed. And that's probably, I would say, probably of all the teeth that are removed, 95% lie in that category. So again, when a tooth is removed, that's really not the issue or the final solution. The real question is, well, what's going to come after that? How do we get a tooth back? Because we need to get teeth back. Number one, to be able to chew properly, we need to have back teeth and front teeth. And also, we need to have our teeth replaced, because the teeth either on the top or the bottom, whichever the case may be, the teeth need to be replaced because they hold the other teeth around them in place. And the best way to kind of describe that or understand that is I talk about books in a bookshelf. So if you take a book out of a bookshelf, what happens? Well, the other books fall into that space, okay? And that's what happens with teeth. When you take a tooth out, if you don't go back and replace it, the other teeth fall into that space. So teeth on either side of where the missing tooth will fall into the space, or a tooth on the top that opposes the bottom tooth will super erupt and drift into that space. And so that can cause a lot of problems. If the teeth fall into the space from the top or from the sides, it can cause problems with chewing, because as the tooth shift, then they don't meet properly, so it can cause problems with chewing. Also, The teeth that actually fall into the space because of their malposition or shifting, they can then become more vulnerable to tooth decay and gum disease. Okay, so we want to try to keep the teeth in the right alignment by, if we lose a tooth, by putting a tooth back in. So if we go back to the bookshelf example, what we want to do is, if we take a book out before the other books fall in, we want to put a book back in there to preserve the alignment of the books in the bookshelf. So anyway, so what about when we take a tooth out? What happens? Well, it's not what you would think. Most people think, like, if you have an injury, let's say like you have a cut on your arm or hand, well, you'll just kind of get a scab and the tissue will pull together and you may wind up with a very small scar there. But the tissue actually fills in and everything is fine, okay? But in teeth, in the jaws, it doesn't actually occur like that. It's much more healing, but it doesn't, the shape and so forth of the jaw where the tooth is removed doesn't really return to normal. Actually, what happens is when you remove a tooth, it leaves a hole, which we call the socket where the tooth was, okay? But instead of just healing over, that socket actually collapses down, okay? So I have a cup here, and this cup represents where the tooth was, okay? So we take the tooth out, we have a socket, okay? But the way the socket heals is that it actually collapses in. So it would be like this, okay? So the bone then fills into the collapsed socket. Well, the problem with that is that leaves a defect, okay? So if we were wanting to put like a dental implant to replace that tooth, now instead of having, a normal size socket, okay, you have this collapsed down area of bone, okay? So that's a problem. Because you may not be able to get an implant in there, or you may have to compromise and put a smaller, more narrow implant than what you would like, which could be problems long term. So what we would like, on the other hand, is we would like that when we take the tooth out, that the socket heals in its original form, okay? So this is where regeneration comes in, okay? And actually, technically, we call it grafting, okay? And probably some of you have heard about bone grafting because it's become more popular in dentistry in the last 20 years, primarily because of the use of implants, and primarily because we have to have bone to put implants into. So that's what's driven the movement in dentistry to develop regenerative procedures, which we call grafting. And in particular, when we take a tooth out, we have to repair and regenerate the bone. And we actually call that socket grafting or socket preservation grafting. Because what we're going to do is when the tooth comes out, instead of letting it just collapse in and leave a big divot, we're going to place material into the socket so that it regenerates. Now I have a couple of other examples here and models of what happens to teeth when it collapses. So again, this model shows us, and you may be able to see this, I hope, that there is a defect here and here when the bone collapses down. And then on the other side, it shows that the bone is wider here because it was repaired or grafted at the time the teeth were taken out. Here's another more obvious model of what happens when we lose teeth. A lot of people don't realize that when we lose teeth, we also lose bone because of the natural healing process of the body. It doesn't fill the bone in all the way like it would on the skin. The bone actually collapses down and it melts away. So here's one side of a person's jaw. Now, here's the other side where the bone, as you can see, has collapsed and resorbed, okay? So nothing regenerative has been done here, and so over time, this is what we see. Now, to kind of develop that point further, what happens if we lose all of our teeth, okay? So here I have a series of models that shows what happens over time if we lose all of our teeth. So here is where we're starting with full complement of teeth, and you can see that there's plenty of bone support. If all the teeth are removed, within a few years, what you'll see is that the bone will start to resorb, okay? Now you got to remember the gum tissue is on top of the bone. So what you'll see in the mouth, it'll look like the gums are starting to shrink, okay? But again, the gums are over the bone sort of like carpet is over a floor. So it's actually not the gum tissue itself that's shrinking, it's the floor underneath or the bone. So as this process continues, we get more and more shrinkage, okay? So here is an example of someone who's probably had the teeth removed and now the bone has been resorbing over a period of 10 or 12, 15 years, okay? Now, in its more advanced or most advanced form, the mandible, and this applies for the upper jaw too, it becomes, we call it like a pencil mandible, okay? And so this is a very severe case. This person has probably been missing teeth for many, many years, probably 15 or 20 years. And I often tell people or ask people, I'll say, can you visualize a little old man or lady and it looks like their nose and their chin are meeting, like they're coming together. And pretty much everybody has seen somebody that looks like that. And I'll say, why do you think that is? You think that's just because they're older, like maybe they're in their 70s or 80s? Is that just a natural part of getting older? Well, of course, most people don't think about that. And the truth is, no, that is not a natural part of getting older. The reason that occurs is because they've lost their teeth at a younger age. When they put the denture in, the denture doesn't stimulate the bone enough like natural teeth does to preserve the bone. And so therefore it resorbs and it resorbs and it resorbs over time. And so this is what they look like after many years of resorption. And of course, the other problem with this is, as the bone resorbs for people that wear dentures, the denture gets bigger and bigger to compensate for the loss of the bone. But there's smaller and smaller amounts of the denture to try to hang on to. So the denture, unfortunately, becomes more and more loose, or at least it feels loose to the patient. And it's not because the way the denture is made, okay? It's not the fault of the denture. It's the fault of the loss of bone throughout the whole jaw that doesn't allow enough for the denture to hold on to stabilize or to chew with, and therefore the denture becomes loose and it also feels big because you're having to build the denture up to compensate for the loss of bone, which, by the way, that bone supports our face and the muscles that attach to that. So as we lose bone throughout our jaws, if we lose all of our teeth, then what we lose is muscle attachment and support. So that leads to wrinkling around the mouth, and it leads to dentures that are large and don't fit very well, all because of the loss of bone. So I think we all understand pretty well the problems with bone loss. So this is why regenerative dentistry has become an important treatment option or modality in dentistry. And I'm talking about bone grafting in particular, because either number one, we want to prevent the loss of bone when possible if a tooth is lost, or the second thing is, can we actually reverse the process and go from here to here? So that's what we're going to talk about next. So getting back to our example of our single socket here that has collapsed, okay? So the socket's collapsed down like this, and now once it collapses down, then there is some bone that forms in there. But unfortunately, there's a divot there, right? And so we don't want that. So very simple thing to do to preserve the loss of bone, because again, we're not just thinking about losing the tooth. We have to think about what's going to come after that to replace the tooth. So how can we repair the bone so it doesn't collapse down? So very simple thing to do is put graft material or regenerative material into the socket at the time that the tooth is taken out. That's called a socket graft or a simple kind of bone graft. So we put regenerative material in here so we can pretend like we would be filling this cup up with sand, okay? And then we put a little kind of a lid over the top of that to hold it in place. And then the gum tissue, we suture over the top to the gum tissue to hold that in. And then what happens is, over the course of the next 2 to 3 months, this all fills in. And guess what? When we're all done, the bone is preserved, and we have a nice piece of bone is the way I like to describe it, to put an implant into. Okay, so that we can put our book back in the bookshelf and prevent all the other books from falling in. So the next question that people often wonder or ask is, well, what do you put in there? What regenerates the bone? What can stimulate the regeneration of bone? And so there's a variety of materials. Some come from animals, some come from humans, some are synthetic. And the latest that is super cool, which I've used all these materials, and I'm using also the latest material, actually comes from the person themselves. Where could we get bone from a person and put it into the socket so that we could regenerate? Interesting question. So hang in there and I'll tell you what that is in just a minute. So what are these other materials? Like I said, we can use synthetics. So this is material that's basically made in a lab that is impregnated with minerals. It's kind of like a sandy sort of material, some of it, and we put it into the socket, put the lid over it, suture it. That's one way to do it. What else? Well, we can use actual ground up bone from animals. We can use bone from a cow, bovine, and we pack the socket with the bovine bone, put the little, we call it a membrane. I like to talk about it like a lid. We put a little lid over the top to hold it in and put our sutures over the lid. And the bovine or the cow bone will grow over time. New bone will form in there, okay? And when I say new bone, what actually happens is that when you put that bovine bone in there, the body sees it and it recognizes it, and it says, well, this isn't quite what we normally like in here, and it resorbs it, but when it resorbs, new bone, it stimulates the formation of new bone. So over time, all that, or most of that cow bone is resorbed, and new bone is replaced. Comes in as its replacement. The third thing, which I like the most, I've used the others a little bit, but the other thing that I like the most until the most recent development is human cadaver bone. So you can get bone, bone in a bottle from a human being that's passed, obviously. And you can pack that human cadaver bone in. It's from the same species, so it's a little more compatible than cow bone, or sometimes they've even used pig. But it's still the same concept. You pack the cadaver bone in, and then you put a little lid over it and suture over it, and the body then sees that. It resorbs the cadaver bone, and as the cadaver bone is released or resorbed, it actually releases a protein in that bone that stimulates bone formation. And then, like I said, this takes about 4 months for new bone to fill into the socket. Okay, so I know that you're all in great suspense about what is the last material used for grafting that comes from the human being, okay, from yourself. So we're talking about what is it from your own body that we can take and essentially, I guess you could say, transplant and put into the socket to regenerate bone. And this kind of sounds crazy, but it actually works better than anything else in my experience. We actually now take the tooth that we extracted, if it's decayed, whatever, any sort of infection or decay on that tooth, we clean all that up, or we clean all that out, and then we actually put it in a tooth grinder and we grind up the tooth. Okay, we grind up primarily the root, okay, of the tooth. And then we sterilize it and purify it. And now we have this tooth that was ground up into tiny, tiny particles. And this looks really more like sand. And then we use the person's own tooth. We go back and we fill the socket with the ground up root of the tooth. And then we put our little membrane or lid over the top and suture over it. So by far, that is something that everybody would want because it actually comes from yourself. And the interesting thing about it is that even the root of the tooth, the same process occurs. The body comes in, it sees that material, and it breaks it down, okay? But in the process of breaking that down, resorbing it, there are proteins in the root of the tooth, even more than in cadaver bone, that allow the release of proteins or mechanisms that stimulate bone growth in that area. One of the proteins that's released is called BMP, which we call bone. That's short for bone morphogenic protein. So anyway, that's released when the ground up particles are broken down by the body and new bone forms in there. So that's how we can regenerate bone in a socket. Okay, so that is more of a preservation type of procedure because we're taking something out, we're putting something in at the time we're taking it out. Okay, you got to remember at the time that we're taking it out, there's still a socket there. Okay, it hasn't had time to collapse. So we put the material in, It's kind of like filling up this cup here and put the lid on, and lo and behold, in 4 months when it heals, it's all preserved. That's why we call it socket preservation grafting. So that's the best way to do it. So if you have to have a tooth removed and you know that there's going to be a replacement that's going to be required, you always need to ask your dentist, well, are we going to graft this? How are we going to replace a tooth that is removed? That's a very critical question. And if you don't have a good answer to that, certainly I'm happy to answer that question and call our office, and we can give you some advice on that. We do these procedures on a daily basis. So what about if a tooth has been removed and there was no discussion about preserving the socket, and now it's 5 or 6 years down the road and we have a big defect there? And you go to an office and the doctor says, well, we could get an implant in there, or we would like to put one in there, but there's not enough bone now because there was no grafting done at the time. And so now that bone is divoted out, like we see here in this model. Okay, there's a divot there. Or like this. This is a really much bigger divot. So there's not enough bone there, so we can't place an implant. Okay, so we can't get the teeth back. Well, we can't place the implant with what's there, but we can do a procedure to regenerate bone there too. Okay, so how do we do that? Well, the materials that we use for that, again, could come from a cow, could come from another human being, or if you have access to a tooth from the individual, you could use that as your graft. But you got to remember, this would be somebody that had a tooth or a few teeth removed years ago. The rest of the teeth, let's say for the sake of argument, are okay. So that's not an option. We don't want to take a healthy tooth out to grind it to use it as a graft. So anyway, we have to think about, well, we could use particulated cadaver bone from a human or from a cow. So in these cases, what we do is we can either do a particle, the bone can be particulated, or in a lot of cases, you can buy it as like a chunk, okay? So you can actually get a little rectangular block of bone and from a tissue bank, okay? What you do is like in this case here, what we would do is we would open the gum tissue up to reveal the bone underneath, and then we would put our block right there on top of the bone, and then we would put a couple of screws in there to secure the block of bone onto the native bone, onto the person's actual jawbone. And then, of course, we would put a little cover over that, and then we would bring the tissue back over that block and suture that over, okay? And so then over time, what would happen is the cells from the native bone would grow up and invade into the block. They would slowly resorb that and replace it with with the individual's own bone. And so over time, you can build a segment of bone back up. Okay, so now instead of being down here, we have bone more up to here, and then we can put some implants in. Okay, so that's another that's a technique using the block graft. Another technique that I talked about is you could use particles. Okay, like particle of cadaver bone. Okay. But it's hard to keep the particles packed in place because there's nothing holding it in. So one thing that can be done, this gets very interesting, you can use another material from the individual that will act as a glue to hold the particles together, and you can form a block with those particles and stick it, and it'll stick and adhere to the bone, kind of like almost like gluing it, okay? And that's where we come into another very interesting regenerative material, which, again, I'm building the suspense here. What could it possibly be? What could we possibly take in a dental office? We're not talking about in a hospital. What could we possibly take in a dental office from the human body that would help regenerate tissue? Not only help regenerate tissue, but fight infection and accelerate healing at the same time. What could that be? So I'm going to tell you right now what it is. So what we do is the tissue that we take is blood. And so what I do in my office is we will draw blood. We'll get about 8 test tubes of blood that are about 8 cc's in a test tube. So about, between 60 and 70 cc's or milliliters of blood. So we draw that, okay, just like when you have your blood drawn for a blood test, except we take more of that than they would take for a blood test. So we got 8 test tubes of blood. What do we do with that? Well, we take those test tubes and we put them in a centrifuge. A centrifuge is a machine that spins around at a very, very high rate. So we drop the test tubes into the centrifuge and we spin it at a high rate. And we spin it at a very specific speed, okay, for a very specific time, okay? Because what we do at a certain speed and at a certain time, the blood has 2 very important components. As you probably know, the biggest component that makes the red blood is the red blood cell, okay? So we've got red blood cells in blood, but we also have another very, very important component, which is responsible for healing, okay? And that's platelets. And then there's also a protein in there called fibrin or fibrinogen, which is a very important part of the healing cascade and of having a wound heal over. So we separate red blood cells out from the healing components of the blood. Now, what's interesting is what we're doing is, out of 1 test tube of blood, we're actually concentrating at the bottom of the test tube the platelets and fibrinogen, which are the healing components of the blood. And the red blood cells are more at the top, and then on top of them is actually a little clear layer of plasma. So when we've spun this down after about 8 minutes at a certain RPM or certain power of spinning, we take the test tubes out, and we'll see a little clear layer at the top. That's plasma. We don't want that. We'll see another layer of dark red. Those are red blood cells. We don't want that, so we throw those away. But at the bottom of the test tube, we have platelets and fibrinogen, okay? And this is what I call a super healing clot, because what we've done is we've taken the components of the blood and condensed down the good stuff that we need for healing. As a matter of fact, this clot has a name, and it's called leukocyte-rich, platelet-rich fibrin, okay? Now, you don't have to remember that because there won't be a test at the end of the podcast today. But we call it LPRF, okay? So all you have to think about it is it's just it's a super healing clot. So we take the super healing clot out of the test tubes, And sometimes we form them into little plugs, or sometimes we actually flatten them out kind of like a little pancake. Okay. Either way, what we can do is then chop that stuff up and we mix it with our bone graft, our particulate bone graft, or you could even use it in a block graft. And it causes the particle bone to stick together and to want to stick to the bone where you're trying to graft. And so we mix that up and then we stick it onto the jawbone. And then we again close the tissue over it. And because the LPRF is a super healing clot, it enhances the healing in that surgical area. And because it's rich in leukocytes, which are white blood cells, which are the cells that fight infection, it also helps reduce the chance of infection. Anytime you do surgery, wherever it is, if it's in the mouth, anywhere in the body, you're creating a wound. And I always tell people this. And all wounds are always susceptible to infection. So one of the big advantages of putting LPRF into your graft is that it also has a very strong, actually has live red blood cells, okay, or excuse me, white blood cells or cells that fight infection. So you're actually introducing concentrated amounts of white blood cells to fight infection to keep the risk of infection to a minimum. So these are two methods that can be used to regenerate bone in the jaws where there where the bone was damaged and had been resorbed and there's not enough. So we can regenerate that by doing either one of these procedures. So let's see. I wanted to also show actually and go back for just a minute to revisit this, where we talked about the different stages of bone loss over time. And actually we started here and we went here and then here and then here. Okay. I brought with me another model of an actual individual that we did some implants on. And just to show you that this is real, sometimes we can make, it's called a stereolithic model. So we can take a CT of a person's jaw and then actually create a real live three-dimensional model that we can hold in our hands. But just so you all know that this is actually real, this is an actual real patient that I treated, okay? Now this over here is a model, okay? But this is actually a real person, okay? And this is his lower jaw, all right? Believe it or not, we didn't have to do any grafting here. That probably seems pretty hard to believe, but it was a very challenging case because you had to place the implants exactly in the right place. You didn't have any leeway for mistakes because this is so narrow. But actually in this individual, we were able to put, I think, 5 implants in here and then do the procedure where the implants are put in and then we secure a set of teeth on those implants that day. And so he's doing great. He's probably about 2 years post-op now, and came in about a month ago, and he's doing really good. Just a kind of a side story. This poor guy couldn't eat anything, right? I mean, okay, if you go back to something like this, at least there's a little ridge for the bone to hang on to, but this guy's like flat, flat as a pancake. I mean, his tongue is way up over where his jaw is, okay? And he was miserable, and he couldn't eat lettuce. He couldn't eat a lot of stuff that he wanted to eat. Fortunately, we were able to get the implants in and build the teeth that go on it, and he's doing great now. But the reason why I'm showing this is just because this does happen in real life. So, some other little things here to talk about as far as regenerative procedures. Sometimes we have to do what's called sinus grafting. So, what's that about? Well, first of all, the maxillary sinus is associated with the upper back teeth. Okay? So, in the back part of your upper jaw, and let's see, we can use this model here. Okay. So, in the back part of your upper jaw, there's an air pocket above that. And that air pocket is called the maxillary sinus. And we have one on the right side, one on the left side. And sometimes the roots of the teeth, or the air pocket, comes down very, very low, so that the roots of the teeth go up through the air pocket. And so if we lose teeth in this area, sometimes there's not enough bone because the air pocket comes down low, and there's not enough bone to put an implant in, because if you go through the bone very far, you'll go into the sinus. And you don't want to put an implant, which is an anchor, into air, right? It'd be like pushing a screw through particle board and nothing on the other side. Okay, instead of if you put particle board on a 2x4 and run it through there into the 2x4, you're anchored in. Great. But if you just go through the particle board and it's not anchored in and there's just air there, you're not going to have anything very stable. And so it is with implants. So there are a couple of procedures that can be done to grow bone actually up in the maxillary sinus where we don't typically have bone. Okay. So one basically procedure that we do is we get to the floor of the sinus by coming up through the bottom of the bone, and we kind of create like a little trap door, okay, and we slowly kind of push the bone up. Bone is pliable, so if you do it carefully, you can kind of carefully green stick fracture the bone up, and we kind of create a little dome at the sinus floor, and then we can put our grafting material. Okay, we could use particulated tooth, we could use cadaver bone, we could use LPRF, or we could use combinations of those. And we put that up in that little dome area, and then guess what? There's a hole there, okay, where we were doing this, and then we just plug the hole with the implant, and voila. In 3 to 4 months, you'll have a little dome of bone growing over the implant, where before there was just an air pocket. So that's one way of doing it. Another way of doing it, which is more invasive, is we actually can do a surgery where we reflect back the gum tissue in that area, and this one really requires seeing a model. We make a little opening way above the teeth into the sinus, and then we go into the sinus, and there's a little membrane in there, a little lining that we lift up, and then we put bone underneath that lining, and we can grow bone up in the maxillary sinus, okay? And then we just close the tissue over it, and that's how we get bone up in there. And again, we would use the same graft material. I would use cadaver bone, and I would probably use LPRF, the supraclot, to graft bone and grow bone in the maxillary sinus. Again, the whole idea is to create enough bone so that there's no air pocket, so that when you or at least minimize the air pocket so that when you put your implant in, you're putting it in the solid bone. Actually, I think we've covered everything pretty well about grafting today. We can talk also about soft tissue grafting, which is having to do more with the gums. But I think we'll probably save that for another day. But now you know what regenerative dentistry is all about. Now you know that if you do have to lose a tooth and it's not a wisdom tooth, that one of the first questions you should be asking, or your dentist should be thinking about, is not just losing the tooth, but what's going to go there after you lose that tooth? What kind of book are we going to put in right away so that the books in the bookshelf don't all collapse? So now you know that in order for the socket to heal properly, that in most cases a graft needs to be done. There is actually one other concept that I'm going to touch on very briefly, and that is that if we're specifically doing implants, and usually this is why we're in need of doing the regenerative procedure, because we need the bone. But here's another concept. What if, instead of graft material, what if you just went ahead and put the implant in the socket, right? I mean, instead of putting the graft material, if we know we're going to get an implant in there, okay, why can't we just put an implant in and, skip the graft material? And the answer to that is you can do that under certain circumstances, okay? You have to have enough bone to anchor the implant into. The bone needs to be suitably dense, okay? And the other thing about that is that there is still a little bit of grafting required, because unlike this paper cup, or maybe I'll kind of distort it here, the socket is actually oval, okay? An implant is a screw. Now, screws are not oval, they're round, okay, so that they can screw into things, okay? So you're putting a round peg into an oval area. That means there's going to be some space somewhere between the peg and the oval part of the socket. So that can create problems because it can create instability for the implant. However, the other question is, well, if you put the round peg in the oval and there's a space there, what happens in that space? Well, what you do normally is, if the space is very big, you go ahead and put graft material in there as a supplement to fill that so you get bone growing in. If the implant can obliterate that to where there's virtually no space, then you're okay. But the thing about that is you have to have the exact right conditions for that to occur. And a lot of times you don't have all those conditions lining up to predictably put an implant in there. It just depends upon the site and the shape of the socket and how much bone there is beyond that socket to anchor the implant in. So that is another thing that, and it's talked about, take the tooth out and put the implant in, and you can avoid grafting altogether. However, that really depends upon the individual, and you have to have all the right prerequisites, the right things there in order to do that. Because if not, and you put an implant into an area where the implant cannot be stable, what will happen is in a few weeks or a month or two later, number one, it either get very infected, or even worse, the patient comes back and the implant's in their hand and they're like, well, guess what came out last night? And so in that case, then you have to start all over. And actually what you have to do is then go back, regraft the bone like a normal socket graft, allow 4 months to heal, and then attempt to place the implant. So placing an implant through a socket can be done. You just have to, the surgeon has to be extremely careful and very much aware of the conditions and prerequisites that need to be there before even considering doing that. So anyway, thank you for listening. I hope you learned something today. I enjoyed giving this presentation. And if you have more questions about regenerative dentistry, about bone grafting, about how to preserve sockets after the teeth are removed, or how to regenerate bone where there isn't bone, or how to, if you think maybe an implant could be placed where your tooth is that needs to be taken out, I would love to see you. Again, I'm Dr. Chris Hughes. My phone number is 618-993-3100. We're on Route 13 in the Logan Professional Park at 504 Rushing Drive, across the street from the Southern Illinois Orthopedic Center. And you can also listen to more of my podcasts. I have videos, and I have a lot of information on my practice at HughesDentalArtsCenter.com. So I look forward to talking to you again, and have a great day. Thank you. Bye-bye.